All right, good morning, everyone. Welcome to Pediatric Learn Rounds. Today's speaker, and happy Halloween, it's actually happy Diwali as well today, so whoever's celebrating. Today's speaker is Dr. Joao Neto. He's one of our soon-to-be graduating pediatric residents. He completed his medical school training in Brazil and will graduate in December and pursue outpatient general pediatric practice. He's passionate about weight loss and gamification of care and is planning on obtaining obesity medicine certification. Please join me in welcoming Dr. Neto.
Thank you. Hello guys, good morning. So let's talk a little bit about obesity. I know it's like it's a well-known topic. I hope I can contribute a little bit, bringing something new to the table. So the learning objectives over here will be review the current statistic trends in pediatric obesity, and then compare and contrast the accessibility of obesity treatment, which is very important for our patients. Review the key components of obesity evaluation and treatment. Review the most common obesity adverse health outcomes, and learn evidence-based guidelines for obesity treatment in the general specifically for general pediatric settings. So a little bit about statistics. We have obesity in the United States is the most prevalent and consequential public health problems in every ages, not just in pediatrics. And is increasing in prevalence in comorbidities. Over time, for example, it tripled from 5% in 1963 to 19% in 2017. Currently, we have like 14.4 million children and adolescents with obesity, which means like one of every 5 kids are affected. So this graph shows a trend since 1963 until 2018. And what I want to highlight over here is this decrease that we had around in here 2005, and then increased again. It decreased again in 2011, and then now is uptrending again. And this decrease can be attributed to several factors, like, for example, changes in nutritional policies in the state and local programs, like, for example, farmers market incentives, community gardens, safe roads to school programs, which improve walking and biking infrastructure, and also industry changes with some food companies were formulating products to reduce sugar and also increasing parental awareness. Two examples that I found will be VERB. This program for the CDC was a CDC campaign happening in 2002 to 2006 that encouraged teenagers to be more physically active through fun and engaging messages and activities. And also on the right side, you can see this Let's Move program created by Michelle Obama in 2010. It tackled childhood obesity and had several different programs, including improving school lunches and healthier options, and also increasing physical activity at school and making healthy, affordable food more accessible to families, and also increasing public awareness in promoting health, eating, and exercises. And And why they stop is not a subjective of this presentation, but some things that we need to consider is the lifespan of the programs, and also mostly the increase in screen time with TV, video games, and smartphones, and also some socioeconomic factors, like, for example, disparities that we have with different populations and safe environments for physical activities. So the AAP recognizes obesity as a chronic disease and with lifelong consequences. And it's important to highlight the physiologic exposure to adversities, like mainly the socio-economical and environmental exposures that, because living in adversity will generate this chronic stress, which with increase on cortisol, and also with that will alter your energy regulation and also increase the risk for obesity onset and also aggravating the already established obesity. And I have this quotation for this AAP guidelines that we're gonna discuss in a few that say this: as the environment has become increasingly obesogenic, access to evidence-based treatment has become even more crucial. And this is what we're gonna talk in a few minutes. So we have this equity considerations because obesity does not affect populations group equally. It will be, and that's why it's important to understand the role of the social determinants of health, because this will be more prevalent in more susceptible populations, like if you have like a poverty and children who lives in under-resourced communities and families that have immigrated and children who experience discrimination, stigma, and racism will be more at risk. And moreover, if you already have obesity, these experiences like bullying and weight stigma, teasing at school may perpetuate the obesity also. So this is a graph that shows the prevalence among different populations. And I just want to highlight that like non-Hispanic Asian boys and girls will be less affected. It may be because of the cultural, they are more disciplined than the rest of the cultures, and also the diet, they tend to be, right? And also, the most affected will be the non-Hispanic Black girls and Mexican boys. So, about social determinants of health, they have 5 key domains, and they play a powerful role on obesity risk factors and also access to treatment, which can ultimately change the health outcomes. And in these social determinants will influence the obesity formation and also creates barrier for the treatment. So this is a very broad concept, but these 5 domains will be, so we're going to discuss. So the economic factors will influence the outcome also, right? So we have the limited income for the families, also the job insecurity, inflexible work schedule, will make it difficult for people to engage in the treatment, and also have a restricted access to healthy food, because cheap food will be more calorie dense, like processed foods, and also access to gym membership and weight management programs. So in the educational part, we're gonna think about poor health literacy, which can lead to misunderstanding of nutritional facts, label, and which can lead to patients be victims of false industry advertisements. Like, for example, they say that fruit snacks are healthy, but they usually are candy with fruit juice. Granola bars being healthy, but they are loaded with sugar. Sports drinks, they also are loaded with sugar. Mainly teenagers, they take a lot because of the electrolytes. And breakfast cereal, also, they advertise as fortified, so you think you're gonna give a good thing to your child, but they are colored things also. And babies, also the canned baby food, they are rich in added sugar, in sodium for motivation, BPAs, and they have nutritional nutrient loss. And then you have the healthcare accessibility and equality. Because of lack of insurance coverage will limit access to preventive care and also obesity screenings and treatment. The neighborhood also will affect the environment. The neighborhood affect like food deserts when you have like a less fresh food available to families, and also neighborhoods with more fast food as well. And the social context with is also very important because will be influenced by all the well-being of the patient. So the social norms and cultural norms around food will influence, like for example, immigrants from I'm gonna say South America. I'm from South America, right? Over there, McDonald's is kind of fancy. People dress up to go to McDonald's, and it's kind of expensive too. So you came here, it's very cheap. So like, okay, I'm gonna do a lot of McDonald's, and so it's a cultural thing. And also Hispanic more than the others. They value more overweight kids. They perceive as healthy. And they have their diet also is very high in calories with tortillas, chips. It's very delicious. Everybody loves it, but it's calorie dense. And this may lead also the social context to discrimination, racism, which leads to chronic stress in this vicious cycle. So those are the adverse health outcomes coming from obesity. I'm not gonna discuss all of them, everybody knows, but just one point, most of them used to be exclusive for adults, and we are gonna see in younger kids over time because of that. And think about is a life course approach that we need to keep screening for that. Because we need to start treatment as early as possible and also throughout the whole life until adulthood. Okay, so let's go to this for the part of this clinical practice guideline on obesity. I got this from the AAP website, and if you like scan this QR code, it'll go straight to this page, which is, you don't require subscription either. It's a very long article, and they are limited for less than 2 years old. They were not included in the study because this is a very hard population to define and measure excessive adiposity, so this is some limitation. And they don't cover prevention either. So how supposed to be the approach? They highlight this no judgmental approach. They recommend asking permission to talk about BMI and weight to families before they start talking. And then you avoid to identify like a little bit of grammar, like identifying first language, like obese child. You're going to use a person first language child with obesity. And then they reviewed several studies among different populations to identify words that are perceived as neutral, and they are healthy weight, unhealthy weight, any too much weight for age and height, and in Spanish, demasiado peso para su salud. And words perceived as more offensive will be obese, morbidly obese, large, fat, overweight, chubby, and in Spanish, sobrepeso, which means overweight. And then you're gonna coordinate care with a multidisciplinary team, including like the physician, nurses, psychologists, exercise specialists, social workers, schools, and the community. And they have like the several key action statements. They are all based on evidence-based recommendations and regarding evaluation and the treatment of obesity. And these scales, they go from 1 to 13 and covers everything you need to know about obesity. So they have this big chart that I divided in 3 chunks, just to fit in the screen so everybody can see. But we're gonna start with screening, measuring your weight as we do in every visit. And then we're gonna end up having the BMI. We do this in our visit automatically. Just one point, BMI has its own limitations because it doesn't give you exactly the fatty component, the adiposity component, but they are very well used screening tool. It's easy, not expensive at all, and is a valid proxy for measuring underlying adiposity. So, so the evaluation, this graph shows like they are divided by like older and younger than 10 years old. And you're gonna do this comprehensive history, the mental and behavioral health assessment, the social determinants of health, physical activity, and diagnosis studies will be under the physician description. So you have this like a main shoe here. So for until the blood pressure, you're gonna do for everybody. The fasting lipid panel, you're gonna do shoot here because of the other recommendations. If you do screening for lipids when you are 11, and then those labs it also will be under the description, right? And then the treatment will be motivational interviewing, which is a type of therapy. We're going to talk a little bit about that. And this part is divided in 6 years old, 6, 12, and 12 because of the way the studies were performed. Like, for example, these intensive health behavior and lifestyle treatments, CAS 11. It was studied in kids older, 6 and older. So that's why you have the differences in the ages over there. And the pharmacotherapy is only for obesity is only above 12. We have some exceptions. We're going to talk a little bit about that. And so motivational interviewing. So this is sorry. So motivational interviewing is a kind of I put this one first, this acronym rule, just for us to remember to resist, to tell people what to do first, listen, and then understand people's motivation and listen with empathy and empower the person to make choices, which will increase the likelihood for them to pursue the treatment. Now, time is flying, and so I wanted to focus more on the motivational interviewing, but I'm gonna go a little bit quicker so I can fit everything there. So we have divided in engaging, focus, evoking, and planning, which means the engaging you're gonna build rapport, so the patient can this medical patient relationship to create so to make them feel comfortable talking to you about their feelings, their goals, and so you can focus on collaborative settings of goals that will be driven by the patient goals, not only focus on weight loss, because sometimes they want to improve the cardiovascular and sport performance and feeling more confident. So just go from where they prioritize. And then you're gonna evoking, which means you're gonna set up the goal for them. Oh, sorry, you're going to explore their intrinsic motivations to do what they need to do, and then you're gonna plan to set up some collaboratively create a plan that tolerates the individual needs, the preferences, and the circumstances. And you're gonna set realistic goals, breaking down the process into smaller and manageable steps, and celebrate with them all the achievements, and of course anticipate relapse. So you avoid frustration, say that relapse is part of the treatment. So you have the Medicaid coverage policies for the pharmacotherapy. So those are our medications approved for weight loss. The most like a highlight right now will be the semaglutide, but was the last studied and very effective. I want to highlight this part. I don't know if everybody knows there, but the prescriber qualifications, I think is nice because like it's the same expertise as all the medications used in pediatrics, like Tylenol and amoxicillin. So every one of us can describe that. But of course, you need to have the informed consent. And some injectable medications has to have extra teaching, not used as a monotherapy. And if you don't feel comfortable, consider referring to who is comfortable. The major barriers for that will be the price. Like semaglutide will cost around $1,000 per month out of pocket, and insurers may vary in the coverage, and the bureaucracy also with insurance for pre-authorization and also continued authorizations that you need. Sorry. Okay. So the indication for semaglutide, for those medications, not only semaglutide, will be the BMI above 95 percentile, and also it needs to be in combination of the lifestyle changes. If you have comorbidities, may strengthen your likelihood to be approved. And it will be a shared decision making about risk, benefits, and costs. So we have I certify by age. If you're 12 and above, which was the study for semaglutide, you don't need to have comorbidies. But for 8 to 11, you have to. Pharmacotherapy is evolving a lot, so we may have some changes in the future for that. So this is the study that was done in 2000. I forgot when it was done. 2022, and it was approved from the FDA in 2022 when it was published. So this was a randomized controlled trial using semaglutide plus lifestyle modifications, comparing to lifestyle modifications alone. And so in the phase 1, they use like 12 weeks of lifestyle modifications only. and followed by 68 weeks of, you added semaglutide to some part of the population, the other one just stayed with the lifestyle changes. And then this is how they increase the dosage. And those are the results. They are very impressive how much semaglutide, adding semaglutide weight change your weight. And this made me remember about the one study that I learned during med school, life study for losartan, that made like after almost 5 years of following people, they had to stop the study because the intervention group, they were comparing losartan and atenolol, and the study group was, they had like a 13% improvement in cardiovascular deaths and strokes, so they have, was unethical to keep the control group with atenolol, so they stopped. I think it's very similar to me at least, but it doesn't, but semaglutide is not perceived as life-saving, so we cannot do the same thing over here. And also, semaglutide has a limitation of generalizability because of the population they study, and also side effects. Okay. But as you can see, the side effects also you can see in the placebo population, also like 82%. So I don't know how much the side effects over there were reliable because it's reported, right, for the patients. Okay, so let me skip that one. So these show a trend of medication for weight loss over a few years. And you can see how much is increasing the medications. The Saxenda is still the first one because I believe people are more comfortable using since it's longer and longer available. So a little bit about other options for treatment will be a metabolic and bariatric surgery, which I believe will decrease over time because of those medications. But the assessment will be individualized and is a multidisciplinary evaluation, and you need to ensure mental stability, family support, and able to follow up and understand the procedure. And the criteria will be patients has to be above 13 years old, and this is because of the puberty and the skeletal maturity. And also they need to have tried weight loss for 6 months and fail. And then based on BMI, we have two options, which will be above BMI above 35 or 120% of the above the normal with comorbidities, or you can have the BMI above 40 and you don't need comorbidities, but it's likely you will have comorbidity at that point. Okay, so guys, have any questions or discussions? We have 1 minute.
You have time. Okay, plenty of time.
Okay, so it's much better. I should have talked slowly.
You have up to 8:30.
You were true. Thank you. You're right.
Thank you for that very detailed presentation. Especially, I love my little health system science heart. Was very happy with the details of the social determinants of health and all the limitations. And now I have newfound understanding of McDonald's. I never knew that, but it makes sense. It was Popeyes in Jamaica. Yeah. It was very expensive, so it was like a big deal to go get Popeyes. Yeah.
And I was checking like the liability of those like a fast food chains, right? Because they are leading to obesity. So there was one point that people sued in New York, some teenagers sued McDonald's and this is fast food for becoming obese. But they lost because they don't, of course, this chain has a lot of money and good lawyers. And they said that they cannot prevent the outcome because it's their choice to consume that type of food. But they made some changes on like a decrease in the calories, and they made some changes in the menu showing how much calories you're consuming, like so you can pick and choose and then know what you're buying and you're eating.
I have a question, sorry. No, I just had a question on like 2 slides back, the criteria for, is it bariatric surgery?
Yes.
With the, not this slide, with the skeletal maturity, this one. Yeah.
That one.
Yeah, so it says consider full skeletal mature but age greater than 13. And I was just thinking males tend to not be anywhere close to that Tanner stage at 13. Is there a difference in male gender selection when it comes to?
Not based on this protocol that I was checking. It doesn't differentiate between, it's just the age. I think they need to, I think that's why they made this new line, right? Like, because they have 13, but they may not be mature enough to do it because of, you can have some poor nutrition after and compromise your development.
Older sources that'll list out boys and girls different, that'll list females at 13 and males at 15. Oh, some older sources, but not older.
And you may not have run into this, but I think we see, and this I think comes in the immigrant population, we see, this generation is protecting their children from the traumas of their generation, right? And so I see a lot of these kids who are labeled as picky, but yet are obese, that their weights are high. And so they will, like I had one the other day, he's picky, he will only eat McDonald's, right? And so they drive to McDonald's for all of his meals because that's all he'll eat. But their history was, my kid wasn't gonna go hungry, right? Like I don't want my kid to go hungry because we went hungry, as a kid. And so I'm just wondering if there's ever been any correlation if they look at like pickiness, like self-labeled pickiness in these habits, because I think kids like these rich, fatty foods because they do taste good. I don't know, did you see anything out there about like how like the eating habit correlated with, or how they're labeled correlated with?
I think this will be in the part of social determinants of health, like a social part, right? Like because in the social environment you are on, so the family, they have like this food insecurity in the past, so they may compensate later, right? I think this is, you're kind of illustrating that part. And also, and how they perceive, right? Like the health literacy. I have more things to say, I thought I was late. So. But like the health literacy, right? So you may not perceive this as unhealthy, especially this specific example. We see this a lot in the Hispanic population, right? Because they immigrate for having more resources. Myself also, right? So you immigrate for more resources. So, but you may have this misunderstanding of health being like a more overweight, you're healthier, because in our cultures, if you have more money, you can buy more food, and so you gain more weight, which is different. In Brazil, for example, fresh food is cheaper than processed food. So people who are poor, they're skinny, and richer people are more overweight. So you perceive as, okay, so they're overweight, they may have money,
That was, though, the United States at the turn of the 1900s, right? Like if the less suntan you had and the more rotund you were, the more that they perceived that you were wealthy. And so, there was even a cultural shift within the U.S. In that as well.
Yeah. Because you're working outside instead of working in an office, right? And that comes the stereotype, the redneck, right? Because you.
Hey.
Some of those determinants too, we need to be careful what we are unknowingly endorsing. So WIC, parents assume is just healthy food, but it gives you a lot of fruit juice. I have had the most intense discussions with families over fruit juice when a mother was furious with me because she makes her own fruit juice and she knows it doesn't have sugar in it. And I'm trying to explain that you're basically just getting the water and the sugar out of the piece of fruit, and you're missing all the fibers that change how your body absorbs the sugar and changes how it's affecting you. And
You're talking about dry?
the child understood it and the mother never accepted it.
Yeah.
But that's when it comes to policy in schools, like fries and ketchup are counted as a serving of vegetable or 2 servings
Yes.
of
Yes.
vegetable, which is
And children's
ridiculous.
hospitals that have fast food in their lobby are perceived as it must be healthy because why else would it be in a children's hospital? Which infuriates me that we give kids Pop-Tarts for breakfast in our hospital and have Coke in our refrigerator for them.
And these guidelines also, they highlight
Fired
how
up, nurses all know.
they also highlight how children are targeted by the food industries, specifically for them, right? Like dried fruits also, because they remove all the water there, so they are calorie dense now, and they are okay eating fruit, right? But it is dried. Another misperception on that.
Wondering, do we have a pediatric bariatric program that's up and running?
They'll consult on over 13. Kristen, blanking on her last name, one of the surgeons has experience with adolescent surgery for bariatrics. We've sent a few kids from our clinic over to be evaluated, but I'm not aware that we've had any of them actually have surgery yet at this point.
And the surgery is not
Getting close to it, but then she stopped attending the medical weight loss and wasn't shown to be very responsible in the tasks that they have them do because of trying to tell if they'll follow the strict diet after.
And the surgery is not free of side effects, right? Because they may try to eat the same amount, and they may feel nauseated, like feel not good, and then they will become depressed. So that's why you have to have the mental assess and know what you do, understanding the procedure and everything. Dr. Tameza.
I have a question about medication therapy for help with obesity. I forget how many slides back that was, but it mentioned monotherapy alone is not recommended.
Yeah, that's implying that you're not doing lifestyle medicine with it, that just prescribing is not what we should do.
Exactly. There's, like the semaglutides, you can give those monotherapy, metformin, but it's always in conjunction with
With the lifestyle.
nutrition and lifestyle.
Yeah. Part of the prior auth is you have to state that they're in a program that involves increased exercise and modifications to food. Although none of the studies for lifestyle modification show significant weight loss.
Right.
That's what it baffles me, like,
Yeah.
and to me, is
And
that,
that's where the obesity surgery is, and before the GLPs, obesity surgery was the only thing that's significant.
is that inherently discriminatory? Right, like by necessitating high follow-up and, like the families who can do that, right? I mean, one of our struggles, we have so many families who love the lifestyle clinic, or who have desires, but they just like,
But a frequent visit during a school day
is really hard. And then it also has the academic effects too. Yeah, I think it's interesting. And as we look at like liraglutide, semaglutide, one of the things that's happening in the adult world is they're developing sarcopenia, where they're muscle
That
loss.
was one of my questions, was if you found any articles on
Okay.
sarcopenia, because there's a limited amount, but I did hear a very interesting lecture at one of the Obesity Medicine Association conferences, that our real problem is the sarcopenia, that like playground equipment has to be modified because kids don't have the upper body strength, so like the zip lines and stuff, they are restricting because they can't maintain their body weight.
And then, I mean, granted, obesity has downstream effects, but right, like this is when kids are laying down their muscle mass, right? And so if you curb that in this age range in the middle of adolescence, what's that gonna do? If you because oftentimes I tell my patients, for many of them, as I'm catching it early, I'm not trying to get you to lose weight, trying to get you just to stay more steady.
Catch up.
Yeah, I just let your body catch up. Because I don't want them catabolizing, really. You know, I want them still anabolizing their, and I think the concern is with these medicines that they're just catabolizing everything.
Well, anytime you go on a weight loss diet, you're going to have some % of muscle loss.
Yeah.
When you do body conformation tests on these kids, pound-wise, they have a lot of muscle because they need it to support their body. Percentage-wise, I'm shocked at how many kids are, like, if they're under 40% body fat, I think they're skinny, based on my experience. So many of them are 40, 50, 60% body fat of their weight. Yeah, we have kids with BMIs of 60 plus. And when they lose weight, some of that is going to be muscle mass. What you want to do is minimize the % muscle mass. When people are regaining weight, they're usually not in the gym pumping iron and making it all muscle gain. They're regaining body fat. So that's where when people say you've messed up your metabolism, because body fat has a lower metabolic requirement to maintain it, where muscle is much more metabolically active. It helps improve insulin sensitivity because it's also where we store some of our glucose appropriately. And so I talk to families. I commend the kids when they come in on our body conformation scale. They either have gained or haven't lost weight, but what they've gained is muscle mass. I am just praising the heck out of them because I want them up and moving to improve body muscle mass. And I just wonder how much of our obesity is, you know, you're sitting and scrolling and it's not really that maybe they're even eating excessive calories when you're thinking about like a crazy amount of calories, but more that they're just not developing the muscle mass to improve their metabolic rate. That should our focus be more on getting the kids up and moving and at a younger age and less of, you know, here we are a teenager now and they don't want to do anything physical. They're embarrassed to go to the gym. They don't feel confident about their body. They're not going to make a sports team. And so there's no motivation to move. They live in a neighborhood where they can't safely go out and walk and play. And
Where do you think that there's room for policy changes that would help our bottom line with this moving forward?
I would say
Policy changes
well, in regard to like a
in any
If you could
aspect.
pass legislation, what would you legislate?
what I would well, I would give more because I think the medication, like for these weight loss medications, I think you're supposed to use it for determined period of time, right? I think if I could pass, I would do the health literacy and lifestyle modifications to be to increase people awareness, because like Dr. Paul was saying, you may lose some weight at the beginning, then you gain muscle, and you go to the scale and you see like, okay, I'm back again, like up, but it's a quality weight, so they don't understand it. That's why weight loss management is so hard, because if you have a sore throat, it's easy, right? You'll go and check and give the antibiotic, and that's it. This takes long, like this intervention that we do, this intensive health, behavior, and lifestyle modifications. The study said that it was 26 hours of contact with healthcare providers between 3 and 12 months to have a good outcome. So it's a lot of time and requires a lot of money, right? And I think like this would be something I would do because it's lifelong.
And that study was an intent to treat. In reality, most of those kids did not meet the 26 hours because of missing appointments. They were given appointments that would have been 26 hours. So I was involved in a group that had more insight into what was the study involved and said that in reality that they were unable to maintain that intensity because of kids missing appointments for a variety of reasons, including school commitments.
So I think you showed that graph from the 60s. Now, these years predate me, but I would also it'd be interesting to look at number of screens per home during that time. Because if you look at also what climbed in the 60s was screen availability, and then the takeoff is in the 2000s with the advent of phones. And so, I think we have pushed so hard on the like policies making environments different. What we have yet to push on the legislation on screens. And I think that yes, we don't want to go outside our home, but if inside our home is less entertaining, then what is going to happen, right? Like there's some things that fill a void, right? Like in a community, if there's no activity, then other things can creep in, versus if people are outside their homes, being in a public space, and this is just safe space to have conversation here. Would that actually affect crime, right? Like people were outside their homes more. If it was more of a community, thinking like in, Spain, Latin America, where people tend to spend more time outside their homes as opposed to inside. If kids weren't just like, oh, well, there's nothing to do outside, I want to spend time on a screen.
And also, if you cannot change that, then maybe you can adapt to the situation, right? Like creating something to do with the screen and to lose weight, like this program.
Virtual reality games are fun.
Yeah.
The kids wear the,
Oculus.
Oculus.
And also you can increase family engagement if you do like a family, like the whole family doing together.
Just dance.
Dance, yeah.
Oh, yeah.
So you can adapt like it is evolving.
Any comments, Dr. Olivos?
Any comments? Yeah, it's been a while since I've practiced, clinical medicine patients, and treating obesity was very difficult for me back then, but the cases of success I had were young people that discovered exercise. They started exercising, and that was the one thing that I think really made a difference. And I used to use motivational interviewing, didn't even know what it was called back then, but I did that, and I had a lot of things I tried to encourage them to do, but if you could just get them to exercise, start exercising, getting them to enjoy exercise, that is the major key, I think, in really making a difference.
If you had named it, you could have retired earlier.
What's that?
If you had named motivational interview, it could have been an all-Tals interview. You could have retired 5 years earlier.
Yeah, I wanted to talk a lot about motivational interviewing, but I thought I was running out of time. But because it's very important, and this is not an assessment, right? Motivation interviewing is not an assessment; it's a therapy, right? Because you're talking to the patient and like assessing and making plans with them and creating their insights, to making insights, which lasts longer than just telling them what to do.
Yeah, thank you for.
Thank you very much for coming.